This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey guys, welcome to another episode of It's Not In Your Head. I'm Justine Feitelson here with my co-host, Dr. Dan Bates. Hello,
Hey,
Dan.
Morning, Jess. How are you?
Swell. Afternoon here. Little toasty like last time, but gonna go through this one in an hour or two. So
It continues to be chilly.
yeah, I've learned my lesson in the Septembers here. I'm always like, it's fall, and then I'm like, no, it's not fall. This is the hottest month, and then it'll cool off. So every time. All right. So today we're going to go over another bucket of central sensitization related symptoms. This time we're going to dive into sensory sensitization. So we're going to talk a little bit about what it is, how it develops, why it's so challenging to deal with. And then we're going to get into basically a bunch of the different largely conservative strategies to manage the different specific sensitizers, as well as some of the sensory systems that can get affected with this, which then affects movement. We're not going to focus on that today. I just want to kind of get into the lay of the land a little bit, but then largely focus on those specific drivers and how also that contributes to the output of pain when you get this positive feedback loop between escalating sensitization and more triggers that are basically adding to it. So
very good.
That's the plan for today.
Let's go.
Should we get into it? All right. Yep. So as far as the main, Dan, do you want to actually touch on, before we kind of get into what is sensory sensitization, really how this relates to the definition of nociplastic pain and why a lot of patients who have sensitization develop widespread pain, but then these other buckets of bothersome trigger, because it's not just pain.
The way I think about sensory sensitization in this context is that pain is another sensation. And just like our other senses become amplified, and so we'll step into this, but you get amplification of light, sound, smell, touch, taste, heat, cold, you get food intolerances, you get balance issues. In the same way, those senses are becoming amplified, so is pain becoming amplified. And it just fits into that whole sensory sensitization piece. When you have regional areas that get amplified, we sort of then labeled them with regional pain syndromes like temporomandibular pain syndrome. When you get widespread pain amplification, we label that as fibromyalgia. And we name this sensory pain sensitization nociplastic pain. Nociplastic pain is defined as persistent pain that arises from altered nociception. So nociception is the system that picks up pain sensitization before you have perception, and perception is at the brain level, despite there being no clear evidence of an ongoing injury. And so in that context, the way we would refer to it as, well, we can't find it, so what we do is we blame the brain. But nonetheless, in this setting, that's the way it's defined. The way I think about it more practically is that you've got peripheral sensitization taking place, so your peripheral nerves become hypersensitive. You get upregulation at the nerve root. You then get further sensitization and upregulation of both support cells, which are called microglia, and the nerves themselves, which become increasingly active through a process called long-term potentiation. And that then drives the whole system all the way. So what you've got is you've got neural and nervous system changes, even though when you scan something, that scan looks like it's healed or you can't see inverted commas damage anymore. It's just that our tech isn't good enough to pick up either the neurological or chemical or other cell changes that have taken place within the system.
Yeah. And so you can see how there's basically this windup that occurs. And as that goes on and you get more of these positive feedback loops, you often develop increasing buckets of these sensitization beyond just pain. So that's why often once you have sensitization, it's not just widespread pain, but it's the sensitization to these other sensory inputs. And a lot of other things can add to this besides just the sensitization in and of itself.
One of the other important things with nociplastic pain is that when trying to work out whether you've got it, having other hypersensitivities, so photophobia, which is hypersensitive to light, hypersensitive to sound, hypersensitive to smell, in combination with, fatigue, cognitive dysfunction,
mood issues.
Mood actually they left out. But though when you've got more of those clustered together, you're more likely to have nociplastic pain as part of the mix, which I just think is, the definition in that setting is essentially reflective of the whole physiological process where everything's getting wound up.
Yeah. And so as you're going through this episode and going, ooh, I have that, right? It's not meant to be diagnostic, but that is basically how you can go, geez, I'm probably quite sensitized if I'm having more and more of these things be bothersome. Yeah. So different things can contribute to this, right? Besides just sensitization and that peripheral sensitization interplay, different things can cause peripheral sensitization, from old injuries, scars, right? Surgeries. Neurodivergence is an interesting overlap with all of this, and sort of that sensory sensitivity that a lot of people have to textures, foods, etc., and coexisting diseases like hypermobility that also sort of develop sensitization and other things that you become sensitized to, even if not globally as far as it being as widespread, but kind of that MCAS bucket of smells, foods, etc. So it's not just central sensitization itself, it's these things plus sometimes that persistent sympathetic state with diseases like complex regional pain syndrome that also adds to that output of becoming sensitive to everything, whereas it used to be just pain potentially mainly. So all of that adds to the output of pain over time. And if you don't address these different, I wouldn't call them primary drivers, but they become drivers, it causes an escalation of this long term and makes it much harder to deal with the amplification and the sensitization that you develop globally with anxiety, depression, and more specifically, like Dan was talking about, with TMD, migraine, food allergies, etc.
I think you raise a really important point there, which we are going to focus on today. We're going to focus on the conservative management strategies of each one of these symptoms. And that is important because not focusing on them means that you get this positive feedback loop that just makes things worse. So the way I think about it, if you worry about something, guess what? Your worry gets worse. And it's the same thing. If your light hypersensitivity is active and you don't act and you don't treat your light hypersensitivity, well, then guess what? It gets worse. So it's important that a lot of the time, I see a lot of patients get stuck down in managing these consequences of a process that is taking place higher up. So within this, yes, you are essentially sensitized. Yes, you have sensory hypersensitivity, but what's driving the sensitivity? And we are not going to step into that question today, but that's the bit when I am seeing people that I'm thinking about, okay, what's driving this? What do I need to treat to wind this all back?
Right.
And then secondarily, are they covering off on, okay, this is how you make your light sensitivity, your sound, your blah,
right. In the meantime,
it better,
right? So
do this.
Yeah. So there is that balance between managing symptoms versus curing or getting to them closer down the line. And it's not one or the other, it's both. Obviously, just managing them isn't enough. If you don't give a crap about managing them, relying on Dan to do everything is also a bit tricky. So you want to kind of get it from both ends as best as you can, because otherwise it leads to a lot of these sort of downstream effects that in and of themselves also amplify pain, like GI issues, again, migraine, nausea, dizziness, fatigue, general malaise, emotionally, that grief and anxiety of things that are triggering and bothersome, and a lot of loss and isolation, which I went through post-TBI for many years, because your world basically gets smaller and smaller and smaller when everything bothers you. I didn't go to a movie theater for like 10 years. Going to restaurants was really hard. Doing social things was really difficult. So if you don't have ways to sort of filter it and also expose yourself just enough to sort of become more tolerant over time, you narrow things down too much. And an important caveat that Dan can touch on too is the concept of sensory gain, where, for example, if you're sensitive to hearing, you don't want to be in just total quiet all the time, because then you actually become more sensitive to noise, as opposed to exposing yourself to little bits that are a bit more tolerable, whether it's white noise or sound machines in ways you can tolerate and things like that, so that you're kind of flirting with that line of keeping some introduced, but being respectful of where your nervous system's at and not overwhelming yourself from a sensory perspective.
Yeah. And I think that the last point before we step into actual discussing is that what we're doing here is we are taking the conservative management strategies from, let's say, management of POTS, which is a clear-cut condition, and applying it to the symptom set that you'll see in patients that are centrally sensitized. And so this is not the overwhelming management strategy for POTS, but essentially you take each one of the simple conservative things that don't require essentially blokes like me to help you out, and you can implement it themselves. So let's get on with it.
All right.
Jazz, what do you want to step into?
Let's start with touch. This one's interesting because, again, with CRPS patients, it's overwhelmingly allodynia, extreme neuropathic pain, issues with pressure, textures being uncomfortable, compression being hard to tolerate, but also kind of helpful. Things like even just wind or the breeze, right? I remember sand, all sorts of textures are just very, very bothersome. And when that changes and it's persistent and long-term, it also affects your proprioception. So it's very distracting, and it also gives you incomplete information and changes kind of the brain map that you're working with as you adapt to live with this very disruptive, intrusive, bothersome distraction, which then affects the motor output. So when patients kind of get stuck from a movement perspective, only cueing what they're doing physically and aren't taking into account some of these changes that are happening earlier and dictating that, it makes it hard to change movement patterns and improve inhibition and some of those other things that develop alongside deconditioning. So we'll touch on that a little from a visual and vestibular perspective too, but it's just something to think about as a patient where you can better understand, why is my movement being impacted when I can't feel or sense parts of my body the same? So some of the different tools that I'll use to manage this are compression as tolerated, especially with the POTSI crew, right? From compression garments, elevating things, salt, those things are super important. Graded exposure applied appropriately is also really, really important with this bucket of symptoms. You can sort of spend X amount of time on different textures that are bothersome. I've had patients where it's the tactile sensation of cold on tile that is really irritating, or certain rugs, right? Or carpets.
How do you do gradient exposure for, like, given I've got my strategy for how you do. How do you do a graded exposure for, let's say you've got pain with light touch? How do you do your graded exposure program?
So what I'll do is just how much time can you tolerate it to begin with? Is it 15 seconds on that rug or that cold tile? Cool. Excellent. Start there. Then over time, increase it 20 seconds. The next week, increase it 30 seconds. Next week, a minute, 5 minutes. And so there's not a specific framework that you have to be stuck in. It's just like with temperature, with cold or hot in the shower, increase the time you're exposing yourself to it first with the time, and then potentially the challenge or how aggressive that texture or that sensation is. And so things like toe spacers are also something that can kind of be uncomfortable, but help you get used to that sort of input there. And different insoles, I'll use things. Naboso is a good company that's got a bunch of stuff from a neuro perspective that can help you actually sense places that you feel less sensation than you used to, but they can also be helpful from a desensitization perspective to just wear as much as you tolerate, take them off, and then revisit it. And just over time, you kind of get more used to things that used to be very aggravating and triggering. So
one of the things I use for patients that have a loss of position senses, which you've already mentioned it, is compression. And so, I can't feel where my leg is. What ends up happening when you use compression is that your brain starts using your skin more to define where your limb position is. So as you move something, because it's being compressed, you have, the material moving across your skin. And what ends up happening is you get better position sense. So because
you have feedback.
Because you got better feedback. So it's an interesting way to go about improving your position sense. I think that one of the things I was thinking, and I hadn't considered it before, is that you see patients with CRPS and these type of symptoms have more falls. And so, and even if it's an arm, like it's an arm rather than a leg, they're more likely to have falls. And I think that, if you're one of those patients with CRPS, you are noticing that you've had an increased number of falls, you can then think about, well, what do I need to do to minimize my risks around that? So whether you just, defall, it's kind of like how you child proof the house. But how do you fall proof the house in some ways? So you take out some of the things that, if you land on, you're going to hurt yourself. You can always pop in rails. You can have, commodes for toilets and things along those lines that are annoying because they can be a reminder of, hey, I feel
limitations.
I got limitations. But at the same time, if you can flick that to actually, I feel safer, so that it's not a limitation, it's an improvement in your safety. So it actually facilitates you doing more. That I think is really important as well.
Yeah. And why does that happen? Because your brain, struggles to know like where exactly your foot is. And with foot drop and different things where, again, you like, even with my hip stability, it was because of the CRPS of my foot, I wasn't getting good foot to hip connection because my brain couldn't sense what was coming from the ground well. So then it's really hard for your hips to reflexively engage when they're kind of like, what foot? Let alone when you use an eye walk and you use crutches and you start to really change the way your brain, again, senses where you are in space and what leg. I'm not using my leg anymore. So that trickles up and down the chain. And this is another place where I like to use sometimes KT tape. For example, if someone feels very little on the top of their foot, that down their toes and on the top can help them kind of feel where their foot is so that you fall less because you're more aware of where you are in space. So this is a frustrating, difficult one, but it is one that can be improved and does impact movement positively down the line, especially once you and your brain are working together better. So
all right. What do you do with light?
Check. All right, light. This is Dan's favorite FL41 glasses. So with light,
it's so simple.
It's the go-to.
Works.
Yep, it works. It works every time. So I'll speak in a little bit on visual in general here, but from a light sensitivity perspective, right? It's issues with sunlight, TV, computer screen exposure, sometimes kind of the differences between day and night. And the interventions that I use too are FL41 glasses, blue light glasses. Obviously, if you need to put eye masks on to sort of give yourself a break, automating lights for circadian rhythm and having them be less harsh and a little bit warmer, let alone the angle that, they're on can be helpful. One thing that I find a lot, again, from a movement perspective, is your eyes limiting movement because there's visual field limitations, there's eye muscle weaknesses, there's, differences in your visual field side to side, which then are going to affect kind of your neck position because if you can't see as much out of your eye, you're cool. Your brain will just solve the problem by shifting your head more. And then these neck, tone, scapular stability and things like that. And so working on things like eye tracking, increasing your visual field, imbalances one side to the other, your head and eyes coordinating and tracking together, convergence, all sorts of things like this can affect weaknesses from a visual perspective, which come along oftentimes as a downstream effect of being sensitized, right? Dry eye. Some of those other things also fall under here, Dan, would you put?
Yeah, well, dry eyes is a decrease in the lubricant layer across the eye. It causes hypersensitivity to light. It's one of those differential diagnoses for sensory hypersensitivity within central sensitization. I think a lot of patients can use eye drops as a means of trying to settle down some of that sensitivity, but it's not necessarily the underlying pathology that's driving. But in some patients it is. Certainly if sensory hypersensitivity is the major issue, well then I think that you need to talk to an ophthalmologist or an optometrist about, hey, is this dry eyes rather than is this sensory sensitization? So you don't miss the diagnosis and blame it on, oh, you're just sensitized, which is always the risk. I think one of the things that I do with the FL41 trick is I should just get a set of glasses, but anyway, I've got a lens that I will give to people and go, hey, have a look through this. And not so much reflect on, does it decrease how your eyes feel, like how you're sensory sensitive, but how does it make you feel?
Yeah.
And the interesting thing is that people will look at it and go, that's nice.
Like I feel less anxious.
Yeah, it's bizarre. So I think that there's a lot within that about how just the light can wind you up.
Right.
And taking that hypersensitivity out is really important. We've shouted out to them before, but Avulux, which is a company out of Melbourne, does a set of glasses and a set of lenses that you can get prescription, and I think you can get them worldwide. So they sell worldwide with these. They're not the sort of color of the FL41 glasses. So FL41 glasses are essentially
they got a cool
rose.
Like orangey hint, kind of.
Kind of. They look effectively. They look normal, but basically what they do is they cut out the specific wavelength from light that really winds you up. And they've done some really good studies on it, particularly within the realms of migraines. So for that hypersensitivity that you get when you're developing migraines, these guys have got, the product and the data. So have a look at them. They're pretty good. Good on them.
And that's a great example, Dan, of a specific sensory input of light causing a global sort of impact downstream from an anxiety perspective, because it's annoying, it's bothersome. It's like, oh, this is so aggressive. And so if you can't change that, you have to change why that's happening to begin with, more to a degree. And it's not always something complicated. And these work well, across the board, I find, with people too.
Yep.
Solid. All right.
Balance.
Vestibular. Yes, balance. Sorry, we're not going to, this is its own whole crazy world, but similar as, right, the other sensory systems of proprioception and visual, vestibular also drive sensitization is something that limits and affects movement and is particularly common in the sort of HEDS cervical instability population. Dan, there's a specific disorder around semicircular canal that you wanted to touch on.
Dehiscence syndrome. Oh, it's not that I really wanted to touch on it. It's just that I think that
it's an example.
Balance is, if your vestibular, so if your balance system is off, my experience of that is it really winds up your nervous system. Your brain does not, because your brain is like, yeah. And I've got to say, I find it very difficult to treat once I've got a patient with like a true underlying, balance disorder, to try and wind down everything else. Oh my goodness. It's really, really hard. And, that is you're out of my skill base bucket. And I refer that off to the dizzy guys, because they're just much, much, much better at managing that stuff than I am. And they understand these diagnoses such as semicircular canal, dehiscence syndrome, which, like, to be honest, other than knowing that it exists and in part how to investigate it for it, I don't know how to manage it. Other than, hey, you need somebody smarter than me at this stuff. So go talk to these guys.
Yeah, same. I kind of second Dan on that. Where from a movement perspective, we can look at and tweak and see how the vestibular system is working with or not the visual and proprioceptive system and things like that. But you still have to, just like with sensitization itself, if you have specific underlying disorders, they still have to be treated. If you have vertigo or post-concussive issues, it's not just a movement issue. So outsource that piece. We'll have someone on at some point.
I'll give one proviso. I'm going to give one minute on that. Like, one thing I do like is I do like treating benign positional vertigo, because there's a technique called the Apley's maneuver that you can do. You can teach the patient and they do it by themselves.
Oh, they do it. Nice.
Oh yeah, but it makes you like. You basically lay down, you trigger off your balance issues while you lay there, wait for it to stop, turn, trigger them off again, wait for them to stop, sit up, trigger them again, wait for it. You just do it again and again and again. The person I did this to the most was my mum. So mum turns up one day at home. She's like, tons of vertigo going on. I'm like, what the hell is going on here? She goes, oh yeah, just started it. So I do a whole pike maneuver, which is one of the diagnostic criteria. And I was like, wow, okay, let's do this. I got her to do that for an hour and a half.
Wow.
Like, oh my God. I felt a little bit guilty, but she was sorted afterwards. Yeah.
See? Yeah.
So like, yeah, good outcome.
Yeah. So with post-concussive, right, the vestibular stuff is a challenge. And a lot of people don't realize sometimes that it's a part of things if it isn't a more extreme, obvious, diagnosable thing. If you have vertigo and stuff like that, and if you have a history of that, think about it when you're kind of putting together who you need help from potentially.
Yeah. And I think that one interesting thing there is to try and define between dizziness, which is a sensation of lightheadedness. I feel like I'm going to faint.
Like with Potsy stuff.
Yeah. And then vertigo, which is the room moving around you.
Yeah, so, spinning. Yeah.
And I think do you feel like you're moving, or do you feel like the room is moving? If you feel like the room is moving, it's vertigo. Right. If you think like you're moving, it's dizziness. So it's kind of like simple. I'm sure that's not that's not 100% correct, but it works.
Yeah. All right. Solid. Next bucket.
Sound sensitivity.
Sensitivity. All right. This was one that was also extremely bothersome for me for a lot of years post TBI. The tinnitus, that like bzzz, sounds like there's a little bug in your ear at all times, as well as just being very sensitive to noise, like hyperacusis. And then that obviously causes, like I touched on earlier, social isolation, and you have to be careful of central gain in that context. Conservative strategies are pretty straightforward for this one. Earplugs, right? There's ones that completely eliminate sound and are more noise canceling, which leaves you prone to central gain potentially. Or there's ones that are kind of meant to allow you to hear a little bit, but dampen noise a lot. So if you're out in the world, out in public, it might help you do some things without being as overwhelmed by sound. And some different brands that I've recommended and looked up around this are called Quiet On, Loop. Those Loop ones are very popular. Calmer by Flair, Vibes, Nops, Curved, spelled Curvd. And then there's different things you can do around sound therapy and exposing yourself to noise on purpose to a degree, as well as balancing feeling overwhelmed by sound with quiet time, kind of adult timeouts, giving yourself a break from when it's kind of ramping up too often, and then introducing a bit of white noise and things along those lines to combat potential central gain if you're too quiet.
Yeah, and just once again, central gain is where your brain's trying to bring in and analyze information, in this setting, sound.
So give it
and
to
if you put noise cancelling headphones on, and what takes place is that you block out all that sound,
everything.
What your brain does is go, I can't hear anything.
I don't like this.
Turn up the volume.
Yeah, it's like if you blocked all your proprioception or all your, it'd be like, which is kind of what happens when you feel nothing.
Yeah.
Give me
so as a result, it just turns up the volume. And so by completely blocking out sound, you go in the opposite direction to what you really want to.
You over time would end up hearing quieter noise louder. Basically,
yes.
right?
Yeah, that's the upshot.
Yeah.
Well, so you just need to be.
Upshot,
so how you battle that is, exactly as Juz has said, you run something in the background at the same time. Yeah. So run some music, run a podcast,
If you're neurodivergent, we know you like listening to the same music over and over and over again. Anyway, like I do. You get in a rhythm. Get in a rhythm.
There you go. Put on something that's doof and
and find one of those headphones that are comfy to kind of have in for long periods. And that's why I like those ones that don't completely eliminate noise, because they allow you to be a part of a little more while, again, kind of respecting where you're at and keeping it from being so overwhelming.
With regards to tinnitus, there's actually an app called Audio Cardio. It was developed at Stanford, and it allows you to test your hearing and your tinnitus. That's cool. It looks for specific frequencies that you have poor hearing in, and it then trains you in those ranges. Frequencies. Yeah. So it's a pretty cool little app. It's got some decent data behind it. So it's one of those things that's also worth looking at. So that's Audio Cardio. So yeah.
Solid. It's a good call.
Some of the other things I liked with sound over time is a lot of the time people find that there's one sound that actually really
the most annoying.
Yeah, really gets under their skin.
Frequency.
If you're in Melbourne, a tram going past or something along those lines, because trams can have this mix between high pitch and low pitch type sounds. And so if you find that that's the case, or it's the next door neighbor's dog, or it's whatever, you can take a recording of that sound. You can then put it on a short loop and turn it down so that it's really soft. And so that at a point in time where it's just not loud enough to bug you. And then all you do is expose yourself to it gradually.
Exposure. Yep.
So you just gradually turn it up from 1 to 1.5 to 2
I love
to
this
2.5. And at the same time, extend out your duration. And what you will find is it just down regulates how irritating the noise is. And it's a great little technique, and you have to be a little bit tech savvy to be able to, number one, record it and then edit it on your phone. But it's not too hard
these days though, there's voice recorders built into every phone. So as long as you have a voice recording of it, then you turn the volume up and down.
And if you're not tech savvy enough to do it, find a grandchild or a kid or the next door neighbor to go, dude, sort this out for me, and there'll be somebody young enough that will sort it relatively quickly. So I've liked that from time to time for those specific frequencies that really wind you up.
If it's your mom recorder.
Hey, Mom, can you just say something like, Go to bed.
Go to your room.
Go to bed.
Go to your room.
My youngest one would be like, yeah, say, mom, say go to bed for me. I'm just gonna like work on something because it really annoys me.
Desensitize myself to you. Awesome.
She doesn't need desensitizing.
Oh my God. No. But that's basically what we're trying to do with all of these different buckets and senses is expose yourself enough to kind of get used to it, flirt with that line, downregulate it, and then it's less bothersome and intrusive, whether it's a parent or a dog or the tram.
Or your mum.
Oh, that's good. All right. Good with that one, Dan?
Yeah,
temperature. Yeah, so this one I almost put next to sort of the proprioceptive touch one because it's similar, but it is different because it's specifically to hot or cold, and also difficulty regulating one's body temperature. I put in this, even though that can be a bit more of a dysautonomia thing when you are prone to sweating. When you get too cold, you can't warm up / you get very, very cold, or you are running too hot too often, or your CRPS affected limb potentially tends to get very, very hot, which can also kind of throw off your body temperature. That all goes in here. When you're sensitive to cold, we call it Raynaud's. When you're sensitive to hot, it just doesn't feel good. Like even in San Diego, I'm good now, I would say, but for the first like 4+ years of CRPS, I always had to cover my leg in direct sunlight. So like if I go down to the pool, I'd be okay for a bit, but after like 30-45 minutes, I'm like, man, my leg's kind of so more annoying. And it's from the sunlight, it's from the heat. And so if I just even had a little cloth, thing on it, it kind of provided a bit of a barrier. So that's a sensitivity to that.
I must admit, I find this one really hard to come up with like useful management strategies, like particularly the temperature regulation piece, like where you're it is hard. All of a sudden you're hot, next time you're cold, and like
I'm just practicing for menopause.
I would love to have a good solution for that, but I really don't. I think that one of the things that within this is certain types of pain that people get. So people will get what's called cold hyperalgesia. So it's kind of like icy pain. I use duloxetine, which is also known as Bolter or Andipra. I use those in that setting. It seems to be more effective. Interestingly as well, as a complete aside, I find that people that have got cold hyperalgesia when we are doing spinal cord stimulation are very responsive to neuromodulation. The patient that we start prepping their back and they're like, oh my God, that hurts so much. I'm like, wow, cold hyperalgesia. Sorry about that. But it's a good sign. Yeah. So yeah, just completely anecdotally, but that's kind of what I think I've seen a lot of the time.
Nice. Yeah. And then from a conservative perspective, right, this is also kind of overlapping with some of the other techniques around gradual / graded exposure. I sort of introduced the shower example, right? So if you're sensitive to cold and when you're in the shower, don't go jump in a big cold pool where you can't control it. You can just turn the temperature a little bit cooler, direct it on the part of your body that is either more tolerable or you're trying to desensitize on purpose. And initially, the variable that I play with is the time. And then once you're able to increase time to hot or cold, you can make it more cold or more hot. Me too, the early years of CRPS, I could not, the swelling in my leg and how hot it would get, I would have to ice for like half an hour after every shower because I like really warm showers. So I wanted to enjoy my shower, but it tortured my leg. And so it was this sort of shitty, I have my leg in the shower. I can't put my leg down. I have to ice it after. So managing this was like a whole thing. I hated showers. Showers were awful, but I didn't want to take icy freezing showers. So a way that you can manage that is post, right? Help your affected body part calm down, but expose yourself over time. Like, and now I can go in jacuzzis. Now I can go in pools. I've even done like hot, cold contrast as I've improved, but basically work your way up to that. So toggle the temperature, toggle the time, whether warm or cold. And it's just like exposing yourself more over time to the different textures that we talked about, in the touch examples. And then when it's your body temperature, have different clothing options, have different layers. If you sweat a lot, like don't only have a sweatshirt because you're going to sweat into it. And then it's this whole thing. So keeping your body cool / warm enough, and also knowing what parts of your body are specifically going to get really hot or are prone to freezing. If you have hot or cold CRPS, for example, as they label it in Canada.
You mentioned a couple of clothes to me the other day. Yep. What were they, like some socks and stuff?
Oh yeah, the TOG rated socks or gloves. So that basically is for like camping for really cold weather. And those are the socks that I have to wear in my office in San Diego in the winter. It's pathetic because I have Raynaud's in my feet. So I just get a little bit too cold, and then it's big white patches, can't warm them up. And it's once you get that cold, it's a pain. It's easier to keep yourself from having that response to begin with. So get gloves or socks that are here. They're called TOG rated. I don't know if that's a global term. And then things like when your limb gets really hot at night, for example, direct a fan on it, because then the leg or arm being hot won't get you so hot. So if you can specifically control the most crazy part of your body, it'll help the rest of your body respond less intensely to those.
Interestingly,
those
so although my like I don't have any of these issues other than
Dan's hand is a little messed up right now.
My hand's a bit sore. I got a neuropathic hand. As I said, that's not going to last very long.
He's carrying on with his empathy exercise.
Yeah. Anyway, neuropathic hand pain for the moment. Anyway, no, one of the things I found, I think that you can also use some prevention strategies in that if you don't, like what you just identified is you don't let your hands get cold. My experience of this is kind of when I've been doing some high altitude stuff, hiking, that if my hands get cold, like there's no coming back. I cannot. And then the rest of me is freezing. So what I ended up doing is I ended up buying some gloves with batteries in them.
Yeah.
And so I was able to just start the day with like toasty fingers, such a first world way to do it. But anyway, and as soon as I got through that, I got warm, then I could take them off and there was no issues. Yeah. But if I missed the window, no good.
I'm so glad you brought that up, because I did the same thing when I went to Joshua Tree as my first camping trip with CRPS, and it was going to be really cold at night, really hot during the day, and I knew it was going to suck, and it did physically, but I overcame it and it was fun. But I did the same thing where I was looking for battery powered, like heated socks, but then with the way my CRPS was, that felt really kind of annoying and bothersome. So if you can tolerate socks that have like built-in heating mechanism, that works. Or there's like pads that you also can pop in a microwave, and then you just put them in your boot, for example. So that too then just adds some warmth without adding
and there's the chemical ones and all that stuff.
Yeah. Good. Cool. On to smell sensitivity. Okay, so now we're going to get into some of if you're hypermobile, this is going to be familiar to you. Smell and taste sensitivity. Let's start with smell. Common triggers, obviously, are different scents like perfumes, cleaning products, flowers, store odors. And this also is a bit of a tough one because you can't avoid everything everywhere, and you're not always in total control of your environment. But this is why, for example, with a lot of people who have these sensitivities, our chorus asks people to please not wear perfume or don't come to rehearsal with scented stuff, because then people are screwed. So ideally, if you can have people that are considerate around you, great. The reality is it's not always an option. And so you also have to be able to control your environment as best as you can and cut scents, ventilate where you can, right? Wear masks if and when appropriate. Saline nose sprays can help a little bit with this. And you can potentially test, things with an allergy patch or things like that. But here too, gradual and small exposure can be helpful, but it is a tough one to find that balance with.
I think from a medical perspective, what we've done in the clinic is bring in some HEPA filters, stick them in the rooms. The ones we got are relatively large, so they cover a large area. And so they're sort of not only, taking out particles, but they take out smells because they've got charcoal in them. So that's sort of one way from a practical perspective that you can help patients. But
that's a good one.
I think this one's a hard one to actually manage. There's just this balance between
dryer sheets, laundry, so many things can become so get neutral, right, stuff as much as you can to just decrease that load of the inputs that are coming in that you're kind of reactive to, because you can't eliminate everything. But
taste, going from one hard one to the next
to an even harder one in a way,
to a harder one.
Yeah, I'll make our job on us a little easier today by saying to reference the fatigue episode where we did a bit more of a deep dive into the nutritional bucket of things. But even that was a bit more from the perspective of basic strategies and from a convenience efficiency point of view. But when it comes to intolerances, a lot of the challenges that I see, and the biggest problem people run into typically, is being able to distinguish between sensitivities and true allergies, and going around and around chasing elimination diets where they basically cut complete food groups, a ton of things out of their diet, get really weak and atrophied, which is particularly problematic if you're also hypermobile. And then that kicks things up too. So try to distinguish between what you're truly allergic to. Lactose and gluten are common, versus a lot of things are going to be reactive if you as a human/context environment are basically, like with hypermobility, breaking collagen down really fast. Your body recognizes that as invaders, and it's not the only thing that's happening with. So it's not the strawberries, it's you. Like it's not the single food item, it's you. So how do you decrease general inflammation is a very vague, like unactionable thing in some ways, but just be cautious when you're eliminating things because that could be a slippery slope.
Yeah. I think you've thrown the food intolerances into that. I think about food intolerances and taste sensitivity slightly differently in that I think taste sensitivity is like literally that like flavor gross. Drives me nuts. And I think that within that, there's also the texture side of things.
And those two are very common with the neurodivergent overlap, right? Textures, absolutely. Taste, type, right? A very particular about certain foods, hate other certain foods. That's super common and also is a big
and the other thing with that is that, particularly with the ASD population, they will go with, okay, this is good, this is good, this is good, this is good, and then it's terrible.
It's not good.
And
not good anymore.
Can't do that. And so then it's out. And I think that one of the strategies you can look at if you do have, ASD, is that you can have a rotation program. Yes. So before you get tired of something, rotate to something else.
Yeah.
And so that you're not like completely blowing, okay, that's not an option anymore. That's not an option anymore. That's not an option.
I'm out of options, right? And now there's no things I like in this and no thing. Yeah.
Like so it's the ultimate in picky eaters. But if you recognize that that's what's taking place, I think a lot of we've got a couple of dietitians that we work with at Active Health. They're a great group. They're very neurodivergent savvy.
Aware,
And so they will structure dietary plans for patients early so that they're sort of not getting caught in these settings. And it's interesting. There's not a lot of people that say, I'm taste sensitive, but I think that what happens is that people eat something and they go, I don't like that.
I don't like that.
Just
right.
They just don't eat it straight away.
Right.
So I think probably people are. Just that we don't recognize it as much.
Just call it a like or a dislike. And
it's a like or dislike. And
this overlaps and has a lot of interplay too with the sort of how do you deal with IBS, specific GIT things like SIBO or C. diff even, and when do you do FODMAP or not, and different things with rheumatoid disorders. And so there's a lot of different schools of thought out there, but there's the basics that are kind of true ideally, and then you just have to kind of tweak it based upon what are your pain conditions and what other things are alongside it. And if you can execute FODMAP, great. If that's too cumbersome and a pain, you don't have to go that route, but you have to be aware of what things are you eliminating and why, and what food groups do you have to be more intentional about getting in, or other ways of ingesting things like protein and some of the other things that we've talked about in past episodes. And the nutrition bucket is big. So we'll have different guests on, and there's so much more to talk about nutritionally. It's just from an intolerance sensitivity perspective, keeping it kind of narrow today.
I think that one of the things I do with that, particularly if we're talking in that realm, I will go through and take a history, and I'll be trying to look for, okay, this patient's sensitized. The question is why, and I'll be trying to work out, is this because they've got a whole stack of MCAS symptoms? Is this because they've got an underlying inflammatory disorder? Is this because they've got, they're hypermobile? Is it because they've got a primary sleep disorder that hasn't been sorted? So I'm looking for those things within my history, but within that is also is this all gastrointestinal? There's something, and interestingly, most people have gastrointestinal symptoms within this.
Once you're sensitized, you have IBS stuff. Yeah.
Everybody's labeled with IBS, but it's when that patient is like, I've only got these symptoms. Yes, I've got this neck pain or my pelvic pain or my whatever pain, but I've got this set of symptoms that is, nausea, bloating, vomiting, diarrhea, constipation. Yep. And it's that stuff where you're like, wow, okay, we just need to sort that.
That's a lot of GIT, right?
Yeah. You got
versus
all
a little
the GIT
sprinkle of
stuff
that
and a little sprinkle of everything else. Great. Let's just fix the GIT stuff first. So, and once again, not my major skill base, but once identified, okay, I need to then refer you out. We get you to see a gastroenterologist, go through that whole process, work out, is this something that's actually pathological?
Right.
Is this,
Is it a
work through the
dislike?
SIBOs, do the colonoscopies, do the gastroscopies, tick off all those boxes.
And then you can pick the most appropriate approach,
Yeah.
for you.
But yeah, once again, that's a identify and refer strategy for me because it's not my massive skill base.
Yeah. Well, and this too, you've got to get like the basics down first around meal quality, timing, what are you eating before you then hyper individualize certain diets. So
yes, I do that bit.
Yeah. All right.
The basics. Episode 19
of our podcast.
of our podcast.
What's the name?
What we do. That thing that we do.
What's it called? Yeah.
Episode
it's ours.
It's a rip.
No way.
Yeah.
Excellent. I heard it's really good. Yeah. Check that one out. Okay. Cool. All right. Well, those were essentially the buckets of specific sensitizations as far as kind of an overall recap, right? The overlapping and overall strategies really are something we've touched on before as far as the 3D concepts: downregulate, desensitize, distract. I talk about this in a wind down context, but here we've given different examples of how you can downregulate the system, how you can desensitize from a touch or temperature perspective, and how you can distract with still keeping, things, white noise around or other things that make it less overwhelming, but don't eliminate it completely or put your attention a little bit elsewhere. Graded exposure is a common theme that we've carried throughout when applied appropriately and slowly progressed. Mindful filtering is a piece of these things, and having those, that awareness of what are my triggers and where should I start, is the other sort of not hard part, but important thing to look at. Where look at the lowest hanging fruit, right? Are you super light sensitive and is it really easy to get glasses? Excellent. Start there. You don't have to make it more complicated.
Amazon's got them $60.
Exactly. Then it is.
And then
pairs. Just prioritize. What?
Three pairs? Yeah.
Oh my God. All right. Let me get a team order on there. You want matching glasses, Dan? That'd be cool.
No, I don't think they're going to suit me.
They're going to suit you. I don't think they'd suit me. All right. And then you just prioritize and progress. So now that you've listened to this episode, think about which ones impact you, match the management strategy, right, to the trigger, and then just do it longer over time. And again, we're getting it from both sides as far as managing the symptoms themselves versus, why is it happening to begin with, and kind of getting at that central sensitization and not just the outputs that it creates. But you have to manage them to give yourself a chance. And easy examples of that were glasses for light, earplugs for sound, right? Sensory desensitization, gadgets for touch, and white noise machine, masks, timers, things like that for audio and visual issues. So this one's kind of a nice one because it's not as much behavior change as some of the other things, right? So there are some kind of nice, easy shortcuts that you can integrate and then just rinse and repeat them over time and be patient. The unwinding of these things does take a long time. It is a gradual process. And so don't get frustrated if you don't see big gains quickly. Just stick with it.
Now, one thing I'm going to do is just say, if you're interested in learning this stuff, Juz does teach all this. She teaches it in her program, which she refers to as Basecamp. And have a look at her website. It's resilientwarriorcoachingllc.com.
Thanks, Dan.
And I know. No.
Look at Dan with his marketing hat on. And a nod to me. Thank you.
But here's the thing. I think that we talk, we've talked briefly through all these things. And I think a lot of people still, it's very hard to go, let's listen to Dan and Juz and then implement.
And then do it.
But you do run a very comprehensive program that will take people through. So have a look at Juz's website, catch her on Insta, see what she does. And see if there's something that she's running that might be right for you.
No, I appreciate that a lot, Dan. And because that's what I saw, right? Over and over again is highly sensitized patients have the same sensitivities and challenges, things they have to manage. And the implementation part is what can be a little hard. But at least having all the information and having it organized and having someone step-by-step take you through it in a sustainable way has been both fulfilling for me, and it's a more accessible way to work with me, so that you're not forced to go through a one-on-one mentorship. You can come into a group setting, meet other patients like you, and actually have a lot of fun as we go through and teach this stuff. So, that is the plug on that.
All right.
Anything else come to mind?
No, I'm good. Nope. I'm going to go
get me out of here.
See some patients.
After you stab your hand.
Yeah, I've got to fix my hand.
Do a science experiment. Away we go.
And away we go.
All right. Cool.
Thanks
a lot, guys. Thanks, Dan. We'll see you next time on It's Not In Your Head podcast.
Okay.
Take care.
See you. Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.